Hello and welcome to Sip of Wellness, the podcast where we dive headfirst into the awesome world of healthcare and wellness. Stick around as we chat about all sorts of things, one sip at a time, uncovering all the details that shape how we feel emotionally, mentally, and physically. We're joined by interviews with the experts, sharing facts that'll support you all the way and questions that'll make you think. So grab your favorite drink, find a comfy spot, and let's gulp down some wisdom that'll support you in your journey to a more balanced and vibrant life. I'm Rima, and today we're honored to be joined by Dr. Aparna Gumma. Dr. Aparna, we're happy to have you. Can you tell our listeners and viewers who are seeing you for the first time a bit about yourself, about your journey between the UK and between the UAE?
Yeah, well, thank you for having me, Rima. It's so nice pleasure seeing you here again. So I'm a head of the department and consultant obs and gynae at King's College Hospital, Dubai. And I've been here, started this year actually in January 2023, and I was in UK for 23 years.
Okay.
And I was a maternal medicine lead and a director of medical education in UK.
Okay.
So I made the move and then started as a consultant with the interest in high-risk pregnancy. And I became the head of the department recently in such a big department. Thank you. Thank you. So my passion is mainly high-risk pregnancy, and as a maternal medicine lead, and I used to be the diabetic pregnancy lead in UK. So I specialize in pre-pregnancy counseling and as well as like management of high-risk complex pregnancies.
Okay. Have you seen like any differences, or have you like felt any differences between work here in the UAE versus in the UK?
There are some differences, obviously. UK is much more systematic, like evidence-based practice based on the Royal College of Obstetricians and Gynecologists and nice guidelines, like, they're guidelines, but they're like more like a protocols, like, driven protocols and evidence-based medicine. We are practicing more or less the same here, but there are some changes, like, we follow the DHA guidelines, and then there are some changes which we have to adapt to, but evidence-based practice is the same all over the world.
Yeah,
but the patient population is different. So here in Dubai,
it's very diverse.
Very, very diverse and multicultural. And I have seen patients from some countries, like, which I didn't think that I will be able to see being in UK.
I've met people from countries I've never heard of before here. It's such a diverse country, but that's, I think, the beauty of it. You get to know so many.
I think, it brings the beauty, and then it brings, like, makes you aware of, like, so many other cultures, the beliefs and practices in each country.
Yeah. So Dr. Aparna, when you say you specialize in high-risk pregnancies, what do you mean exactly? Like which category of pregnancies or do you usually specialize in?
Yeah. So I used to see like very, very complex high-risk pregnancies, such as pregnant patients with brain cancer, like survivors, like breast cancer survivors, like renal transplant patients, as well as like patients having cardiac conditions themselves. Epilepsy patients, thyroid disorders like diabetes, hypertension, and I also used to specialize in autoimmune conditions. So patients who had like rheumatoid arthritis or lupus conditions, ankylosing spondylitis. So patients with all sort of medical disorders. Okay. But high risk pregnancy means that any pregnancy where the woman or the fetus or both of them has a higher than chance of having a complications. Compared to other patients which are low-risk pregnancies. That could be influenced due to several factors.
So basically anyone with or who does have or had any pre-existing medical conditions would be classified in their pregnancy as a high-risk pregnancy?
That is true. That is one aspect of high-risk pregnancy, but there is much more, depth into the high-risk pregnancy. Suppose if somebody had like like obstetric history, like what we call as a poor obstetric history. So unfortunately, they may have had recurrent miscarriages, or like they lost the baby, either stillbirth or intrauterine death, or previous babies being small, what we call as growth restriction, or So those patients, like patients who had previous ectopic pregnancies or miscarriages due to several reasons, whether it could be first trimester miscarriages or second trimester due to cervical incompetencies, all those patients would become a high risk. That's another category of high risk pregnancy.
So for example, if a patient comes today and they don't have any pre-existing medical conditions, might they develop a high risk pregnancy during their pregnancy, or it's from the start, either it's a high risk pregnancy or not?
So there will be risk assessment tool, like, main thing like for me is to take a detailed history, look at their family history, personal history, their lifestyle, their habits, and then, what happened with the previous pregnancies. But if it is a first time pregnant and never had any pre-existing medical conditions, then other thing to look for is is there any genetic or chromosomal problems within their family? Because they may not have faced any medical problems, but either the patient or her husband may be carriers of genetic chromosomal conditions.
So for the immediate family, basically.
Yeah, immediate family, which could become, or they may be consanguineous related marriages as well. That could bring in an increased risk as well.
Okay.
So, and the risk can change. They may start the pregnancy as a low risk, but may develop the factors that can influence and make it into high risk pregnancy.
Okay.
I could give examples. Suppose there could be placental abnormalities where the placenta may be low lying, called placenta previa.
Yeah.
Or there is a placental function could be abnormal, which could produce low amounts of fluid, amniotic fluid, or can develop high risk, high amount of fluid, which could bring its own risk. Okay. Or sometimes pregnancy, because the patient is taking care of more of them and be under close observation, we may pick up the conditions that they don't know that they are pre-existing.
Okay.
And it could be a twin pregnancy, triplet pregnancy.
Twin pregnancy is immediately considered a high risk or no?
Yes, it is. Yes, it is. There are different varieties of twin pregnancy. And I don't want to go into too many details of it, but twin pregnancy is it does bring its own joys as well as its own risk.
Yeah, of course.
Yeah.
You mentioned the lifestyle, you look at the lifestyle, not just the genetic background. So when it comes to lifestyle, is it the lifestyle during the last year before conception, or is it during pregnancy?
I think the lifestyle in general, what they have been, how the habits is. One is if they are into habits of smoking, whether it's a vaping, and sometimes I get asked this question, Doctor, I just vape, it's not smoking
vape,
cigarettes.
Shisha it's not the same.
Yeah, so people has this perception that it won't be. Yes, it's less risky compared to regular cigarette smoking and cigar smoking stuff, but it does have still risk. And we are so new into this, there is more and more data coming about, and habits of drinking alcohol or any other drugs that can influence.
Okay.
So that's as well as their BMI. If they're underweight or overweight, both of them
underweight also goes into...
Yes. People only think of high BMI,
exactly.
which more people are aware these days. But underweight, low BMI of 18 and 19, again, it has its own group of risk. Baby can be small as well. They may have fetal growth restriction during the pregnancy.
Okay.
And other thing patients may not be aware is their blood group and RH typing. Okay. So negative blood group people, and sometimes there is a mismatch between the patient and the husband blood groups.
Okay.
So there could be some condition called rhesus, isoimmunization.
Okay.
Again, that can be risky to the baby.
Okay. So what is usually done in this case?
Okay. So it depends upon when we do the blood group and typing in the beginning of the pregnancy, first thing is to check what blood group and the rhesus type sometimes, and then check for antibodies. Okay. Antibody levels, some people can have antibodies because of previous incidences or miscarriages or blood transfusions that could produce chemicals, these antibodies, which can cross the placenta, get to the baby and influence the baby. So if they're antibody positive, we keep an eye and monitor the titers of the antibodies, and then may need to arrange extra scans to check the fetus growth is normal. Sometimes the fetus could become severely anemic and may need transfusion during the pregnancy, within the uterus.
Really? You give blood transfusions during the pregnancy?
Yeah.
Okay.
So it's specialized fetal medicine where you may have to do these procedures, and then you may have to think of delivering the baby early. Yeah.
It's so crazy how far along medicine has come to. You can do all of these things now. Because I remember back in when my mother was pregnant, there wasn't really that concept of high-risk pregnancies. Every pregnancy was just a pregnancy. Because I remember I specifically asked about the rhesus type, the negative and positive, because my mother was a positive. She was positive and we were all negative. So I remember when she delivered, they had to give her a shot or give us a shot. Someone had to be given an injection.
So anti-D injections, so that we give it as a prophylactic during pregnancy and immediately after delivery, so that we protecting the future babies, future pregnancies. I mean, I have seen patients with epilepsy, thyroid disorders is another very very common, and underestimated as well, whether it's underactive thyroid or overactive thyroid. Like yesterday, I had a celebrity patient, Brianna, who was delivered as a high-risk pregnancy.
Baby fade.
Yeah. So I was happy to be part of the journey and look after Brianna and Chris's baby. And she has got Graves' disease, which is overactive thyroid.
Okay.
And there is risk to the baby. And she has fibroids. That's another condition that could have an impact during the pregnancy. So sometimes patients think fibroids may not impact on, but it depends upon whether they needed the surgery and how big it is during the pregnancy. What is the number of fibroids, it can all influence and make it into a high-risk pregnancy.
Okay. Yeah. What is usually the approach for the parents, not just for the doctor, for the parents, if they know that they're walking into a high-risk pregnancy? What can they do? Can they do something to prevent or to lessen the impact of this pregnancy, of the outcomes, or they can't really do anything about it?
Absolutely. There can be a lot of things that can be done. So ideally, I would recommend any patients getting pregnant, to have a pre-pregnancy counseling.
Okay.
So I would always say, help me to help you. Give me all the information. Always been my motto in my career is empower the woman. But to do that, help me to help you. So that if I know all the information and background, your family history, your lifestyle, your habits, and what are all the medical conditions and what are we dealing with, and then I can make a plan and then plan a pregnancy to optimize the best health and have the good habits, exercise, lifestyle. And there are supplements called folic acid, which can improve the development of the brain and the spine development, reduce the congenital malformations of the baby. So we can do all of that. So patients can start looking at their lifestyle first of all. And if there is a BMI is high, again through healthy exercise and dietary habits, and make a plan to improve the weight. And then, if it is underweight, again, there could be options like a dietitian and nutrition review to have a healthy, balanced weight and diet as well at the same time. So they can prepare themselves and together with the doctor, to have a discussion. I would like to empower the woman and educate and keep the couple together, as a partnership, so that they understand how are we going to manage this pregnancy, what can be done before they get pregnant, first of all, and plan the pregnancy to achieve the optimum outcome.
Okay.
Pregnancy is going to be a beautiful journey. And I always say, we are in this together to have healthy, successful outcome, both for the mother and the baby, therefore ultimately the whole family.
So you mentioned in the beginning that lifestyle really does affect the baby and the mother. So if, for example, today I'm a smoker, I drink alcohol, I do all of these things, and I'm planning to get pregnant, not necessarily now, but I'm planning, maybe in a year or so. When do you think the optimal time would be for me to start changing my lifestyle in order to not affect me during my pregnancy?
I would say 3 to 6 months at least, to get back into the shape and adjust to these habits, because there could be withdrawal of these habits to be a body to get used to, and then emotionally ready as well as physically to be ready, and start taking, what we advise is to take folic acid supplements 3 months before you get pregnant.
Even before pregnancy?
Before pregnant.
Okay.
So to improve the brain and spine development. So at least 3 months before to start taking the folic acid. So physically, and if you have to adjust any of these lifestyle changes and look at your weight and balance the diet. So that is the minimum time scale.
Okay. And usually we always talk about these things when it comes to women. Where does the partner, where does the man come into play? Does he also have to have a good BMI, not drink alcohol, have a good diet, or does it just have to do with the women?
So I always say 2 make the baby.
Yeah.
Okay, not just 1. Okay, so both has to be in it together. I always advise my patients to see with the husband together, and then I always ask the husband to say what is his lifestyle habits and look at his BMI and any pre-existing medical conditions for him as well, so that it may not have a direct impact on the baby's health, if he has medical conditions, but the medications he is on, for him to be emotionally and physically ready as well. And I give the same advice to stop smoking and stop drinking alcohol, and then, they can have multivitamin supplements as well to just have an optimum health and optimum BMI, so that, he is able to support the pregnant, in pregnancy and the woman during their journey.
So usually for women, if I can take it from my own perspective, if I today was told, me and my partner, that we're having a high-risk pregnancy, that would freak me out. That would totally affect my journey of pregnancy, and it would change the way I look at my pregnancy. It would stress me out, which in turn will affect the baby. So what do you think can be done? Because idea of a high-risk pregnancy, the idea of high risk in itself is a bit intimidating. So
I can understand, like, if the patient, as a non-medical, and because pregnancy is going to be such a happy time in your life, and such an enjoyable journey as well, like, for the patient and the husband to be like, as soon as we say your pregnancy is a high risk.
Yeah.
And I don't want them to be scared. And I'll sit down, and this is why the pre-pregnancy counseling will help to be in the right state of mind to prepare. And if the risk starts developing within pregnancy, like it changes from low risk to high risk, again, empowering the women and then educating them to say, why is it high risk? And then what are the steps we're going to do? How are we going to monitor the pregnancy? Okay. That means, like, they may need to come into hospital more number of times to have the regular antenatal checkups. It depends on what are we dealing with, like optimizing their medication, because certain medications may have impact and produce like defects in the baby. So I need to adjust those medications. This is an opportunity, if we see them pre-pregnancy, to optimize all those, change them into a good medications that do not impact the baby's growth or, produce defects. But if we started the pregnancy like as a low risk and it turns out to be high risk, there is a reason like why it become high risk. Again, to explaining, like I always say, knowledge is power, and educating and empowering the women to make them understand, so that, if you're giving a medication for a reason, then, they need to understand why it is. Once they know, there are better complaints. All over the world, studies has shown that, if you just prescribe something and you don't explain it to you, patients are not going to be compliant, whether they're pregnant or non-pregnant.
Yeah, true.
So for them to understand, and also understand why we need to do extra growth scans, why we need to do the specialized scans.
That's what I wanted to ask you. Like, are there different scans, frequency of scans? Are they different in terms of high risk?
Yes, they are in high risk pregnancy. So there are some targeted scans we have to do, and then there is a serial growth scans. Like they may need extra growth scans and Doppler's blood flow to check that the baby's growth is going to be okay. And then there is fetal cell DNA testing to look for chromosomal or carrier screening. We started doing carrier screening offering at the moment, so that we can pick up if there's any chromosomal or genetic conditions for my patients, and then we can guide them and give the right advice as well. And there could be like sometimes invasive testing as well, so which is like a CVS or amniocentesis, where we pick up the fetal cells from the fluid.
This is advised for all high-risk pregnancies?
Not all. Only when it is needed.
Okay.
Most of the time it could be like as simple as like having a regular checkups and doing more ultrasound scans, so that we closely monitor, and then some blood test and lab test extra, depends upon which is the condition we are dealing with. Suppose if it is a thyroid condition. So we do need to do every 3 months a thyroid testing, looking for antibodies and like adjust their medication. And I always like have my patients in a multidisciplinary team. So that, if they have a thyroid or a diabetes or hypertensive patients, then, we liaise with the medical team, and make sure that, we are in communication, because the outcome, the studies have shown that if the patient is managed in a multidisciplinary setup, like thyroid patients with an endocrinologist. So I see a lot of diabetes patients, whether they are type 1, type 2 patients, diabetes, or sometimes they develop during pregnancy, which is called gestational diabetes. Again, like to having a diabetic nurse to help them, and the dietitian to help them, as well as endocrinologist. So we're all talking and communicating with each other to make sure that we're getting the best outcome for the mother and the baby.
So for gestational diabetes, it can be easily managed like with nutritional changes and dietitial changes, basically?
Yeah. Most of the patients will manage very well with the dietary control. Once they understand that what's making the blood sugars go high, and then with the dietary adjustments and then monitoring the blood sugars, we can manage. And then if needed, there is medications available, whether it's the tablets, and sometimes we may have to go to the route of insulin. They'll need a little bit extra monitoring with ultrasound scans, because they have a risk of having a macrosomic baby, which is like a big baby.
I wanted to ask basically about genetic, like if for example, my parents or my mother or we had high-risk pregnancies in the family, does that mandate that I'm going to have a high-risk pregnancy as well? Or it's not like that? It doesn't work like this?
So it depends upon what is the genetic condition, the chromosomal condition. This is why we're starting to do the carrier testing as well. So detailed history of the family tree, what is the condition we're doing with, from the patient side, from the husband side, and then look at the family tree to see. And the geneticists will help dealing, and then to see when we can do the test, and there is test available which we can test hundreds of conditions.
Okay.
Okay. And during pregnancy, again, like, we can do NIPT test, like, the quadruple test and like triple test, so that we can pick up if there is any problem with the baby. There is extended chromosomal testing, genetic testing, which we can we do very early within the pregnancy. By 10, 11 weeks, it has evolved so much over the years. Like, we are able to determine the baby's sex by 10 weeks, as well as chromosomal testing. So there's a lot of tests. The medicine has evolved, and I'm impressed over the years, like how medicine keeps on continuously evolving. So it doesn't necessarily mean that you're a high-risk pregnancy. You could be a carrier of a condition. Then we look at to see what is the risk to the baby.
Okay.
So if both partners have there are, again, like the inheritance is different. Sometimes some conditions are dominant. Some conditions, what we call as recessive. That means that baby can be carrier. But not being affected. So because there are so many varieties of conditions, we can look at that to see what is actual risk to your baby.
Okay. So are there things that the family can do aside from like not medicinal, not lifestyle changes per se? Are there things that they can do to decrease more or less the effect of high-risk pregnancies, or to...
It depends on what are we looking at, because if there's genetic conditions, then you are born with it. Like, one of the things which we have seen being in Dubai, because being with very diverse population, consanguineous marriages are common in some countries. Like when we see with the populations, they may be carrying a genetic condition which is transmitted through generations. And they could be like what we call as a blood-related conditions. Okay. Some families can have bleeding disorders, like they tend to bleed more. Some people can have what we call as sticky blood. Clotting problems because they lack certain protein in their blood. So again, that can lead to like increased risk of miscarriages and pregnancy losses and like stillbirths, or increased risk of preeclampsia. Again, by seeing them before, that is the only way. Like, it's personally, because if you are born with this condition, you can't do anything to change it. It is in your genetic genotype.
Definitely.
But then seeing a doctor early and planning a pregnancy, then plan can be made how to like reduce, because miscarriage can be very heartbreaking. Like, each time somebody had a miscarriage, there is a 20% chance of having a second miscarriage. And if somebody has 4 miscarriages, like, they have like a risk, increasing risk, what we call as recurrent miscarriages. But I always try to look at it as a positive way for the patient to say there is a 60% chance of having a normal delivery. Even if you have 4 miscarriages. But we need to find out why someone is having miscarriages, like to help the woman to do the test and see what is the particular reason they've been having miscarriages. Once we identify, then it's very much treatable and manageable to give them a healthy baby to them.
That's so inspirational. Do you have, by the way, like, can you share with us during your career if you had one of these cases where someone had recurrent miscarriages and by the end they carried their baby to term and their baby is now healthy and everything is fine?
Oh, absolutely. There are so many of them. I had a patient with severe endometriosis. I used to... in UK, I was doing like very many cases of endometriosis. So my gynae patients, many of them. And then they come to see me and they had infertility, then they get pregnant, and then there is a risk of having recurrent miscarriages. One of the patients had 3 miscarriages. So by 3rd miscarriage, she came to see me. She was seeing my colleague and being referred to me by 3rd miscarriage. So I managed to do all the tests and identify that she has a condition in her blood which is making her recurrent miscarried. So when I identified and treated her with the next pregnancy, and she went on to have 3 babies. And so every time I have she delivers, she sends me a big bouquet of flowers and chocolates, and then she'll send me a beautiful photo of her with the baby.
That's so sweet.
I managed to see her 3 babies together, and that makes me so happy, like heartwarming. And I have many of those patients,
It is very heartwarming. And especially as you said, once you've identified the issue in the first pregnancy, you can immediately prevent it from happening again. So the second pregnancy and the third pregnancy would be a bit smoother in this case, right?
Absolutely, because, and they will also be less anxious. As I said, it's very emotional and heartbreaking for a woman to keep miscarrying and losing and not knowing what is happening and why she's miscarrying, whether she will ever be able to have a baby, hold the baby in her hands. So once we identify and treat and manage, then she'll be reassured to say, my doctor knows what is my problem. And then I had a successful, healthy baby this time, I'm going to keep doing this.
Definitely.
So she was like, in her mid-30s, and she gave up hope like by the time she came to see me. And she went on to have 3 pregnancies.
Miscarriages. Yeah. But it's so good, like by the end she has 3 babies.
Yeah.
Can we generalize, by the way? Like, can we say that if you had a first high-risk pregnancy, like for your first baby, would you have a second high-risk pregnancy and a third high-risk pregnancy? Or it doesn't have to be that way? Like if you have a normal pregnancy, you can have a second high-risk pregnancy.
Yeah. So, I mean, it doesn't necessarily mean that you have a high-risk pregnancy for whatever reasons last time, as long as it's not a pre-existing medical condition, as long as like, you didn't have like previously poor obstetric history. So I can give you an example. A patient can have a gestational diabetes or preeclampsia in this pregnancy, or she may have twins this pregnancy, which made it high risk. It doesn't mean that next pregnancy is going to be very high risk. Okay, there is it can be a single baby next to pregnancy, and then it may go smoothly and normal. And if somebody developed preeclampsia, gestational diabetes, doesn't mean that they are necessarily going to develop it in the next pregnancy. So it can be like a very nice, smooth pregnancy and low risk pregnancy next time.
Okay.
Yeah.
So for twins and triplets, you're saying these are also considered high risk pregnancies most of the time.
Yes.
So what's usually the approach for dealing with twin pregnancies or triplet pregnancies?
Yeah. So it's identifying that there is a triplet pregnancy or twin pregnancy as early as possible.
Yeah.
And by the scan, we determine what we call as chorionicity. That means the type of the twins. Okay. They could be like, identical twins,
Fraternal.
non-identical twins, and different types of twins. And certain type of twins where they share the placenta, they're in the same sac together, it carries the high risk. So once we determine as
Why
early...
is that?
Okay, because
if you don't mind,
there are 2 babies, and they're carrying they are within their own sacs and the placenta, and it's called dizygotic twins. Okay, that means like each embryo is separate, like, that's the best type of twins to have because they have a very low risk to have any complications. But when they start sharing the same placenta within the same sac, one of them can take more.
And one can take
and
less.
One can get less.
Is that why we always see like a bigger baby and a smaller
baby within the twins? So there is a certain condition called twin-to-twin transfusion syndrome, where like, the one baby is taking more and then other baby is having less. Both babies can have complications. Okay. Once we identify, then there is a schedule we follow, how frequently they need to be seen, and they will have a lot more extra scans and spending a lot more time with their consultant, like to manage it better.
Okay. So something can be done, by the way,
Absolutely.
like regarding these twins, and in order for them not to have one baby take more than the other, something can be done.
Yeah. So there is something called it depends on the connections, like with the blood connections, like arteriovenous connections, what we say, like, the blood flow through the placenta. And sometimes like when one baby start taking more and the other baby start getting less and less and less, it's called twin-to-twin transfusion. There is a technique that has evolved where you can go and laser the blood vessels within the uterus, within the placenta.
Okay.
Yeah.
Perfect.
So once upon a time, like the only option was to deliver, even if they're premature, if they're 28 weeks, 26 weeks, you deliver to make them survive outside. Nowadays, we don't need to do that. We can go and do, it's called intrauterine laser ablation.
Okay.
Yeah, of the blood vessels between the twins, in the placenta, within the uterus.
That's so nice to hear. Really, whenever I hear about these things, I'm more optimistic automatically towards my present and the future of medicine. Like it's so amazing.
It's amazing that the medicine has evolved so much and keep on evolving every day. And we're all learning and practicing evidence-based medicine to provide the best outcomes for the baby.
Yeah, exactly. Usually, by the way, for patients who do have high-risk pregnancies, do they have to have a certain type of delivery, or they can deliver in however way they want? Like, do they have to have a planned C-section or a C-section, or they can deliver normally?
Cesarean section is only needed for obstetric indications for most of these patients. High-risk pregnancy, I think there is a misconception to say a high-risk pregnancy, then I'm meant to have a cesarean section. It's not necessarily true. Again, it depends upon what is the condition we are dealing with and how is the woman coping emotionally, as well as like coping with the physical condition and the medical conditions. And suppose like I have seen pregnancies where in the twin pregnancy, one of the baby died.
Okay.
So it's such a emotional roller coaster journey for the patient, like where you're expecting and you're happy and it became a twin pregnancy.
Yeah.
And suddenly during the pregnancy, one of the baby died.
I can only imagine how hard that is.
And how hard and emotionally to go through that situation sometimes. And it doesn't necessarily mean that you need to have a cesarean section for like, it depends on the emotional mental state, because it brings a lot of anxiety and patients can be depressed as well. They may not have the strength to deliver normally. So it becomes an individualized decision, like, to see what is best for the patient. Again, patients with preeclampsia or diabetes doesn't necessarily mean that, they must have a cesarean section. Again, it depends upon what are we dealing with. And fibroids doesn't mean that they need to have a cesarean section. Okay, only placenta previa, where the placenta covers the cervix completely, is too risky to attempt the vaginal delivery, so they must have a cesarean section for the safe delivery.
For these patients, what can they do for these patients who have experienced miscarriages, even if, for example, they have twins and one of them doesn't make it through? What can they do to prevent or to make sure that they're in the right emotional state so that they can continue to term with the other baby?
Yeah. So I think it depends upon like support, okay? Because pregnancy, the mental health condition pregnancy is very much underestimated. Imagine somebody going through such a turmoil during the pregnancy, which is meant to be the very happy state in their life-changing experience. So support coming from different ways, coming from their obstetrician, first of all, like as a high-risk obstetrician, like I have dealt with many of these scenarios, you become their friend. Rather than like, you develop such a rapport and have a trust, like,
Because you're with them for 9 months,
9
like
months
it's a journey.
It's a journey, like, so it's the duty of the obstetrician to provide that support and comfort and understand the emotional state. And, sometimes they just need a reassurance more and more, like, sometimes they may want to see the doctor even like, to discuss. There may not be any need for obstetric reasons, but they want to see, to have that comfort and the trust and rapport. From the husband point of view, again, it is so difficult for them to cope with the same situation, but to be there for the wife to be supported and the family members to provide that support, to make this journey through. And there is always something known as postpartum depression.
Yes.
For patients who has been through difficult situations during pregnancy or high-risk pregnancy, again, when they deliver, they need to continue to have that support from the doctor and the family and the husband together, because otherwise there is studies which have shown there is increased risk of depression.
Okay. Usually they say that exercise also really helps. I don't know if exercise is really advised for high-risk pregnant people.
So I always recommend a patient to be active during pregnancy. Walking is good, swimming is good, and yoga and Pilates, like stretching exercises. It doesn't mean that high-risk pregnancy that you need absolute bed rest. Gone those
that's
days.
what people think, by the way. They need to stay in bed for like 2-3 months and not do a thing.
Used to be during my mother time and your mother's time. Like in the generation has changed. Like they used to prescribe, like patients will come, like they will say, like my mother had 9 months bed rest. Because she was a high-risk pregnancy.
Exactly.
Thank God that we are not in that generation. We are not in those situations. So I always tell the patient to be active, but, to listen to their body. To listen to their body, and they can continue to exercise, but nothing very strenuous. That would affect it. But being active and brisk walking, especially brisk walking, has shown to be like half an hour of walking every day.
Half an hour.
Walking, like, it helps the physical as well as the mental health.
Yeah, exactly. Because I see actually on Instagram a lot of pregnant women with their bellies like so big in front of them, and they're doing strength training, with the weights and everything. And there's always like that split in opinion. Like some people are like, yeah, it's okay, it's totally fine, you can do strength training, and other people are like, no, you cannot lift weights if you're pregnant. So I don't know, like, what do you usually advise in this case?
So I always tell my patients to say, like, limit the strength training exercises. Like, it's not a complete no, but the trainer needs to be aware and has to be certified that, they are able to manage the pregnant patients during the exercise and support them together. Because pregnancy is a physiological state, but high-risk pregnancy is a different ballgame.
Okay.
Pregnancy in general, like, yes, you can exercise, you can keep, but then, the body changes in so many different ways, and the ligaments are relaxed because of the hormonal changes, and there is like nausea, vomiting, and a lot of body aches and pains and backache will develop as well. So I think the simplest thing to tell the patient is listen to your body. Okay, respect your body, and don't push your body too much to do like strength training exercises so that, with heavy weights.
Yeah, especially that now there is a lot of access to prenatal yoga, prenatal Pilates, all of these exercises that are designed strictly for pregnant women. So it's, I think it would be a much nicer option for a woman to go through all of these things.
Yeah. I absolutely agree, because when we do like this yoga, I recommend this yoga or Pilates and like pelvic strengthening and stretching exercises. That will facilitate like pelvic relaxation to promote the normal delivery as well. So I always tell my patients to try and look into this, and even sitting on the floor, if they're able to sitting on the floor and with support, and I will encourage them to do that and use like sitting on the ball as well. So that will help with the pelvic stretching and relaxation to facilitate the normal delivery.
So sitting on the floor would actually help with the pelvic.
Yeah.
That's interesting. A lot of pregnant women actually go into frenzy when they find out that they're pregnant, because everyone keeps weighing in, aside from their doctors. Everyone in the family starts weighing in on the supplements that they should be taking, multivitamins, all of these things. When I've repeatedly heard that it's mainly folic acid that is needed and required. Are there other things? Are there other supplements that should be taken during pregnancy, or is it just folic acid mainly?
Folic acid is the most essential to start with. As I said, 3 months before and the first 12 weeks, where like, there's brain development, neurodevelopment of the baby is happening. So sometimes, patients do develop anemia very commonly, but because we have to remember that the baby is taking the nutrition for the mother. So most important thing for the mother is to have a healthy, balanced diet. But sometimes, like if they develop anemia, then they will need the iron supplements. And the multivitamins with omega is like, there is some benefits, so that, patients with nausea, vomiting, they do feel tired, and especially with the nausea feeling, they may not be able to eat properly, and therefore they feel tired. So having these multivitamin supplements, again with the calcium supplements, that do help to a certain extent to keep the energy levels up for the pregnant woman. And as we know that in UAE, most of the people are vitamin D deficient.
Yes.
Okay. So in pregnancy, we do recommend like vitamin D supplementation to be taken throughout the pregnancy, as well as like breastfeeding, if they're breastfeeding, for like 3 to 6 months after delivery.
I actually wanted to ask you about the postnatal effect. So if someone had a high-risk pregnancy, postnatally, does it affect them in any way? Or is it just the high risk is just included in the prenatal period? So postnatally, it doesn't affect anything, and they're back to being normal like any other woman, basically?
So the high-risk pregnancy means it should be looked at the prenatal, antenatal, postnatal. Okay. The journey continues. Okay. The obstetrician duty, my duty, doesn't end when we deliver the baby and then give the baby back to the mother, and then they're all happy. Everybody forgets the woman.
Yeah,
everyone focuses on the baby, the beautiful baby. So it depends on what is the condition. I will make sure that we see the patient back for the follow-up, and like looking at the medical conditions. If they've been on medications, that needs to be adjusted. Some of the medications can be stopped immediately after delivery. Suppose if there's a preeclampsia, they've been on blood pressure medications. Women need to be monitored for the blood pressure.
So it doesn't end at delivery?
It doesn't end there. So the journey continues for at least for a few weeks to few months. And also make sure that the mental state of the woman is fine, and with the sleeplessness and with being a newborn baby, to make sure that she's being well supported, and and continue with the multivitamins as well. Again, there could be bleeding during delivery, which can lead to anemia, postpartum anemia it's called. So they may need that iron supplements, they may need that calcium and vitamin D supplementation to continue.
Is there any effect on the baby postnatally whatsoever, or?
It varies. It depends upon like the medical conditions the mother has and the medications she has been on. Sometimes the baby can have withdrawal. Withdrawal depends on the medications the mother has been on.
The baby can have withdrawal.
Baby can have withdrawal. So it depends on the medical conditions. Then we will alert the pediatricians. So the pediatricians will be keeping an eye and do the monitoring of the neonate.
Can you give me a brief example? Because this is a very interesting topic, that the baby can have withdrawal from after delivery, basically from the mother's medication.
Yes, absolutely. Suppose if the patient had severe anxiety and depression, or like any of the mental health conditions, they could be on antidepressant medication. During pregnancy, which will cross the placenta, and some of these medications may not allow the woman to breastfeed even, because they're not recommended to breastfeed. And so the babies, because they've been having this low dose throughout the pregnancy, during as it crosses the placenta, baby can develop withdrawal, and sometimes, unfortunately, baby can have epilepsy, like seizures. Okay. So the pediatrician will be monitoring.
So Dr. Aparna, just as your final word for someone who might be going or might be walking into a high-risk pregnancy or is going through a high-risk pregnancy, what would you tell them? What would your message to them be?
My aim is always to empower and support the patient throughout the journey, and to be part of this journey and make it as smooth as possible. I always say, this is my motto, as I said before, help me to help you. So give me all the detailed history. No need to be scared and no need to be very much anxious about high-risk pregnancy, and be supported by your obstetrician, be supported by your family. Let them be part of your journey, and don't be alone. Don't think that, because it's a high-risk pregnancy, it's going to be a bad outcome. I think the most common misconception for the woman and the family is, because it's a high-risk pregnancy, something bad is going to happen to them, either the mother or the baby. Okay. And it won't be like that, and it shouldn't be like that. When the pregnancy is well managed, well treated as it should be, and supported and empowered the woman with education and then right medication, right testing, and keeping a close eye monitoring, you can have a healthy, successful outcome. Have a beautiful baby in your hands, and you don't need to worry.
I think always to maintain a positive outlook on things, to do your research, to, as you said, knowledge is power. If you choose a proper consultant, you will be in safe hands, and knowing that you're in safe hands actually gives you all the emotional support that you need. And as you said, not every high-risk pregnancy ends up, a lot of high-risk pregnancies now are managed very properly. So it's not something to be afraid of.
Yeah.
Absolutely.
Nothing to be afraid of.
Exactly. Thank you so much for this amazing talk, Dr. Aparna. For everyone who enjoyed our topic today with Dr. Aparna Gumma, you can find her in King's College Hospital, London, Dubai. Thank you so much again for you being here, Dr. Aparna, and sharing your thoughts and expertise with us.
Thank you for having me, Rima. It was a pleasure.
Thank you so much. If you like this episode, make sure to put your thumbs up on this video and subscribe to our channel for more educational topics with experts. See you next Friday.